Welcome back to the Waco Family Medicine POCUS curriculum. This module will cover the basics of MSK Ultrasound. And I'll be upfront and say that since my training was mainly in the inpatient and emergency room setting, that MSK Ultrasound is one of my weaker areas. But that being said, I hope we can learn together and benefit from the expertise of our sports medicine faculty and fellows who use this modality day in and day out. As with other areas of POCUS, what I'll be going over is just the tip of the iceberg. There are some deep wells here into which you can dive, but we'll remain focused on general concepts and a focused look at some of the most common clinical questions seen in the primary care office. As an overview of this module, we'll discuss how to recognize different structures commonly seen during the MSK scans, including muscles, bones, tendons, nerves, skin, and soft tissue pathology, and things like that. We'll each review the relevant knobs and settings needed on the ultrasound machine to get an appropriate view of each of those structures that you may be using your ultrasound to take a look at. We'll also talk about scanning technique and go over some of the tips and tricks to help make relevant anatomy more pronounced to diagnose common problems. I'll go over some of the common conditions we see in the skin and soft tissue diseases, such as abscesses, phlebitis, cellulitis, ganglion cysts, dermoid cysts, foreign bodies, etc., and we'll have a series of videos covering the major points and going over common presentations and ultrasound findings for those conditions. We'll then end the module with a quick dive into ultrasound-guided procedures that you may want to incorporate into your practice. So let's start off to think about what kind of questions you may come up with when you're evaluating a patient in the office that has lots of different MSK complaints. What would some of the indications be for you to reach for an ultrasound probe as an imaging modality of choice? The most common indication for MSK ultrasound is pain affecting a particular region of the body. And while sometimes your exam or the patient history can identify a readily apparent cause of that pain, sometimes I use my ultrasound to help narrow down my findings by looking at structures that may be involved in an otherwise equivocal exam. If a patient comes in with mechanical symptoms such as locking or catching or popping of a joint, that's a reason that I'll often reach for an ultrasound as my initial modality of imaging, and then progress to radiographs or CT or MRI if I need better detail or am more concerned about an intra-articular process that I'm not going to be able to see well using my ultrasound. Skin and soft tissue changes are another common reason that I'll pull out the ultrasound because of the high availability and resolution of these images using my linear transducer. And then I mentioned that I use the MSK ultrasound techniques for diagnostic clarification, but I also pull it out when patients have tried conservative management for common conditions and haven't responded, sometimes just to confirm that diagnosis or to rule out some things that might otherwise be common. So there's a ton of different reasons why you may want to reach for your ultrasound when evaluating an MSK complaint. Before we jump into pathology, let's review the ultrasonographic appearance of typical structures seen when performing an MSK and soft tissue ultrasound. Bones are some of the easiest structures to recognize on ultrasound. They're readily identifiable by their highly echogenic, linear appearance that has posterior acoustic shadowing. Generally, bones are palpable, or at least have palpable prominences that help guide where to place our transducers. Bones should be continuous and linear and appear as bright lines, which may show artifacts such as reverberation if we've gone over that in previous videos, so you know what to look for there. In this clip, we see a section of a bone, but pay attention to this irregularity that I've circled in red. This is what a fracture can look like on ultrasound. And in fact, ultrasound is more sensitive for fractures than x-rays are for many different bones like the ribs and in pediatric patients especially. So moving on to muscles, and this is a video of the chest wall, which shows layers of thoracic muscles overlying two rib bones in a pleural line, which you might recognize from our lung ultrasound series. Muscles generally have a uniform, striated appearance on ultrasound, with some degree of linearity that shows when the muscle fibers are traveling in a particular direction. Small fascial planes wrap around the muscles, and fat collections within the muscles will help give it these small little white foci in an otherwise hypoechoic field of myocytes. I hope that you can appreciate the large fascial plane between the muscles, which is the bright line seen, let me get my pointer out, right here in between these two muscle planes. And this bright white line is seen between muscle layers and helps distinguish between different muscles that may be deep to each other. This is important because, as a general rule, vessels and nerves will travel in these fascial planes and can be identified for venous access or for nerve blocks, and should be avoided if you're trying to inject or aspirate deeper structures. Tendons are fibrous, linear continuations of muscles that attach to bones or other articular surfaces to aid in the mechanical component of movement. Tendons are highly linear and should have a uniform appearance, thickness, and echotexture across their length from origin to insertion. Tendons are often the site of irritation or inflammation and injury, all of which can be seen using ultrasound. However, because of their linearity, tendons are also subject to extreme changes in their reflective properties and thus their brightness on ultrasound. And this is known as anisotropy, which we have talked about previously, but I want to review because it's such an important concept. So let's remind ourselves what I mean by anisotropy and the physics behind this artifact. So this clip shows a biceps tendon, which is right here in this groove, traveling through the bicipital groove of the humerus. And here you can see that the greater and lesser trochanter of the humerus on either side of the biceps tendon. And as the probe is fanned through the tendon, its appearance changes from being highly echogenic and bright, like right now, to darker, as seen here, and more hypoechoic and almost anechoic at the very end. So on the right side of the screen, I've drawn a schematic of this. So here we have a probe with a little mound of ultrasound gel in blue, and then we have some muscle fibers and subcutaneous tissue, and then we've got our tendon down here represented by the linear dashed lines. So when the incoming ultrasound beams are perpendicular to these fibers, they reflect their waves strongly back up towards the probe, which results in a very bright return on the screen, showing a highly echogenic or very bright component. However, if the angle of inclination is changed so that the incoming ultrasound waves hit the reflective tendon at an angle, this reflection gets bounced off away from the probe. So now the majority of the ultrasound signal that returns up to the surface of the body is not being detected by the transducer, and this results in a dark or hypoechoic signal. For this reason, when the angle of your probe hits a tendon at an angle, whether that's because your probe is tilted or the tendon is curved or running at an angle inside the body, you may mistake a tendon for a vessel or another fluid-filled structure rather than the dense connective tissue that it is. I want you to get in the habit of tilting and fanning your probe when looking at tendons to confirm this anisotropy, because it can help you differentiate between vessels, nerves, and tendons, which are all very common targets for our point-of-care exams. Tendons demonstrate anisotropy in both the long and short axis, but generally it's more pronounced in the short axis. However, we usually take measurements of tendons in the long axis because it's helpful for us to compare how wide the tendon is across multiple points. Inflamed tendons, such as seen in acute tendinitis or more chronic tendinosis, will have thickening over the area of irritation. Similarly, tendon tears and ruptures are best seen in the long axis, where small gaps in the linearity can be visualized. So as an example, here's an Achilles tendon that's been ruptured following a traumatic injury. You can see the linearity of the normal tendon best along the right side of the image, right around here. However, in this area that's outlined by the red arrows, you see a hypoechoic region that disrupts the normal tendon with some thickening in the area when we compare it to the other side of the normal tendon, which likely represents a hematoma and edema in the injured area. Yikes. Next, let's take a look at nerves. Nerves are, similarly to tendons, very highly linear structures. In the long axis, they're often indistinguishable from tendons. Some clues that help you differentiate them are 1, looking where they travel, as tendons usually travel in the same plane as muscles and eventually will transition into the typical muscular appearance on ultrasound, whereas nerves will have the same structure as you trace them distally or proximally. Nerves also travel in a slightly different spot, usually in neurovascular bundles along the fascial planes. So seeing a structure traveling near vasculature might help you differentiate it as a nerve. Despite their similarity to tendons, there are a couple notable differences between tendons and nerves. Firstly, when viewed in the short or transverse axis, nerves sometimes have what we call a honeycomb appearance. And you can see a good example of that right here in this clip, this honeycomb-looking structure. Right in the middle is a large nerve. However, as tendons tend to travel more distally in the body, they often lose this honeycomb appearance and look more like a tendon, more striated and linear. Another important difference is that nerves will have less anisotropy than tendons. So they're still linear, they're still going to have moderate changes to their appearance when incubated at different angles, but in areas like the carpal tunnel, where tendons and nerves are traveling closely together, the nerve will stay more visible as you fan your probe, and the tendons will more rapidly fade out of view because the tendons have a higher anisotropic property. When considering your approach to MSK ultrasound, some basic tenets help us orient our clinical questions and exam approach. Not to be overly simplistic, but remember that a thorough physical exam taking place prior to putting the ultrasound on a patient can often render your diagnosis on its own, or at least narrow it down to a few key areas that can then be investigated using ultrasound to make a final diagnosis. In broad kindergarten terms, remember that you'll run into symptoms of MSK problems when things that should connect don't connect, or things that should move don't move. So moving to that first problem, when something that should connect doesn't connect, that could be a muscle tear or a bone fracture or a tendon rupture. All of these are disruptions of the normal connections that allow us to move freely. Similarly, if structures such as neuromas or cysts or foreign bodies or scar tissue have limited the normal motion of tendons or joints, mechanical symptoms will often follow on your physical exam or your patient's history. Anytime that mechanics are disrupted, there is a risk of an inflammatory response, which generally shows up as first edema, meaning that we'll see hypoechoic fluid on ultrasound, followed by tissue thickening if this inflammatory process is long-standing and the edema continues. And then there is some possibility of something called hypervascularity, as blood vessels will grow in to supply that injured tissue with nutrients and oxygen to help the body's process of self-maintenance and healing. Other tips that are important to keep in mind when you're interpreting MSK ultrasound is that you have to have a mastery of the anatomy in question. So if you can't picture the rotator cuff tendons in your mind's eye and identify their anatomy, taking a look at the rotator cuff with your ultrasound is going to be pretty difficult, if not impossible. Any abnormalities should be confirmed in multiple planes so that the artifacts such as anisotropy, which can mask or mimic pathology, can be minimized. And dynamic exams that involve the patient going through a range of motion or stressing the affected structures will usually be more helpful than taking still pictures or a single view alone. The probe of choice for most MSK exams is going to be the high-frequency linear array probe. The excellent resolution of these typically superficial structures is paramount for proper imaging. Alternatively, probes such as the hockey stick probe, if you have one, may be preferred for small joints or when doing procedures. Or occasionally, reaching for the curvilinear probe may be needed for adequate depth to view the shoulder or hip joints in bigger-bodied patients. As structures are often superficial, it may be helpful to use copious gel pads or even utilize a water bath to visualize the distal extremities, whose nooks, curves, and crannies may make good probe-skin interface a challenge. Summarized again, most of the challenges with MSK ultrasound result from knowledge gaps regarding the anatomy that's being studied, artifacts such as anisotropy, or poor contact between the probe and the skin, which can be offset with the corrective measures we've already discussed. And with that, that's our introduction to MSK ultrasound. I hope that you've realized we've talked about some of the different indications for the exams, what normal MSK structures appear like when looking at the different structures of the body using ultrasound. You know which probe to choose, and you've gotten an overview of the scanning technique. And next, we'll start jumping into some of the different pathologies that we sometimes see, particularly affecting different joints and areas of the body.